So Dr. Beckett is the Assistant Director for the Academic Core and the Director of the Evidence-Based Practice Certificate Program for the Helene Fold Health Trust National Institute for Evidence. Oh my, that is a mouthful.
Yes.
For evidence-based practice in nursing and healthcare, and an assistant professor of clinical nursing at the Ohio State University College of Nursing, teaching evidence-based practice at the master's and doctoral levels. She's working to integrate EBP into academic curriculum across all levels and is directing efforts at the Fold to implement and oversee an interprofessional certificate in evidence-based practice. Dr. Beckett has been a nurse for 42 years, working in various leadership, academic, and research roles. Her research focus has involved perinatal, pediatrics, and family, rural and underserved communities, and populations using quantitative, qualitative, and evidence-based practice methodologies. Dr. Beckett has been mentoring, teaching, and leading evidence-based practice in the clinical and academic settings for over 15 years. Okay, Dr. Beckett, the floor is yours.
Thank you so much. I'm so honored to be here, and I've really enjoyed the presentations this morning. Such great, rich content and information. So as we all know, our COVID has kind of encompassed all of us for the last couple of years. In 19, right at the beginning of this, we were asked at the Fold Institute to identify several key practice issues and delve into the evidence, try to find what was out there, and present webinars and information back to organizations across the country and then eventually the globe. And one of those topics I was charged with was looking at what are the nursing models out there? Are the staffing models out there that might help with this overwhelming staffing dilemma? And what we have found is not only did it help during COVID, but now that we still have an extreme shortage of nursing, it's still very applicable today with our ever-changing practice. So what I'd like to share with you today is the work of our team. Myself and Dr. Inga Zavenskis led a team of 6 from at OSU and Michigan State. We did a joint state approach to this to look at our region, but then also to look at the country. And we actually developed an integrated review of team nursing and delegation and those implications for staffing. And that's what we'd like to share with you today. Get my clicker. So again, I'm presenting on behalf of our team. And the goal for today would be to describe at least one strategy that an evidence-based recommendation during pandemic or crisis times for staffing, and to justify how teams can maximize staffing skills and experience during those situations. Had no conflicts of interest, and this was not a sponsored project. So this was our team. It was an amazing group. We had 3 DNP students, and we had the faculty, but again, from Michigan and OSU, so came with very different perspectives, but it made it a very rich experience to work across universities and across states. So the overall purpose of the review was to identify what were best practice staffing models. I have been a nurse for a very long time and have seen all the different models come and go. And so we were really wanting to know, was there a best practice model? And then to really provide that support to organizations to help them during that pandemic. So we followed an evidence-based practice methodology. So we started with that inquiry. What were people wondering about? And the big question that came to us from multiple hospitals across Ohio and Michigan was, what about team nursing? This is what we're being asked to do. Is it best practice? What are the strategies? So we wanted to look not just at team nursing, but the other models. So we looked at team nursing, which is assigning in pairs with a team lead and a whole team with them. Patient allocation models, which is one nurse caring for a team independently. And then primary nursing, which was assigning a key nurse that might be responsible for that patient throughout their hospitalization or throughout a multiple day stay, and their responsibilities would overarch even more than 24 hours. So we compared the different models across the literature, and I know that there's lots of information, but I want to make sure I get a chance to cover the details. But we went into detail on each of these to try to really define the models so that if we were to recommend a model, we would know what that would be. So again, team nursing, you've got the nurse manager, you have a couple of teams, and in those teams, you may have a mix of LPNs or LVNs, RNs, patient care techs or CNAs, and then any other designated individuals. Patient allocated models, there's a manager with just RNs, and they tend to then encompass its primary care. And we'd have one nurse's aide or patient safety assistant to then support the entire team. And many hospitals are using both of these models. Australia and University of Minnesota published a lot about primary nursing, and this is more in that case management model or a care coordinator type of model, but the nurse has 24-hour responsibility and looks at assigning, who needs to be there. They have core teams of staff that work with that patient. And this would be an example would be in PICUs or NICUs, where they want to be able to have that continuity of care throughout that stay in that intensive care unit. And it involves an interprofessional approach as well. What happened in the pandemic is we ended up looking at things kind of in this augmented staffing model. This was published in the Society of Critical Care Medicine, but it really began to look at how can we use resources in a way that we can have safe patient care, but by using people that may not be as skilled or need, in that area. So we floated nurses, we floated providers, we floated non-licensed people into those areas that needed care and tried to figure out the best approach to that. So it was a kind of a modified team approach. And often we'd end up having mentor support with the different individuals. So what we found in reviewing the models and then beginning to look at the literature is that, it's a very complex process. We used PICO questions to guide our search of the literature. We had 2 of them. In hospitals, how does team nursing compared to other care models affect outcomes? And then we looked in hospitals, how does team nursing delegation compared to primary nursing affect outcomes? So we wanted to look at both of those approaches. We ended up doing a huge review of the literature, ended up keeping 45 articles between the 2 areas of focus. And this is just shows you kind of the diversity of the evidence for our team nursing and the nursing models, primarily descriptive studies. A few were, randomized control trials, a systematic review that might have randomized control trials, systematic reviews of a group of descriptive studies, but primarily low-level descriptive level studies. But what we did find is with team nursing, the outcomes were a little bit everywhere. And this was true with the other models as well. We did see some great reductions in falls, length of stay, medication errors, increased patient satisfaction in many of the studies. But in a few of the studies, you'll notice the red ones, there was actually an increase in problems, or there was no real statistical change in the outcomes. As we looked at nursing outcomes, and these were 3 key systematic reviews, the data was kind of the same way. We did see some absolute positives and increases, but there's also some opportunities for no statistical significance and some decrease. But what we looked at is overall, based on all the literature that we reviewed, what kinds of recommendations could we do based on this process? We also looked at organizational outcomes, and it was really, this was really in the gray because team nursing didn't really show a true benefit except in one article. And I think the reason for this is we're not reducing staff. We're using combinations of staff to care for complex patients. So it's not really a cost saver, but in the long run, it can help produce those better outcomes. For delegation, very similar literature, lots of descriptive information, a few systematic reviews of descriptive studies, a couple of randomized controlled trials and some expert opinions, but generally it was in that descriptive level of evidence. What we did find in the delegation content were some clear patterns of what was needed to then make whatever that model was, whether it was team nursing, primary care, more effective, and clear role descriptions, accountability, and clear perception of what that accountability looked like, role knowledge and task, supervision, support, mindful communication, and delegation decision-making training. The more that the nurses and the staff they delegate to understand the process and the accountability of the process, the more positive the outcomes were. We did a review of all of the state boards of nursing, and this is just a sample of what we found. And the one in blue is the National Council on State Boards. Consistently across the board, nursing responsibilities, how to delegate to unlicensed people, the delegee responsibilities, and that communication was very consistent across. And what came out the strongest were the 5 rights of delegation. So really making sure that they understood the right task, under which the right circumstances, the right person, the right directions, and the right supervision. So as we began to pull all this together, we wanted to create a recommendation that would make sense, that was very usable. And so we looked at that finalizing the delegation piece, and it was really looking at the processes and the responsibility of those that are going to delegate, and the obligation and the accomplishment of the task, and the accountability. So with delegation, if you have the authority to delegate, you also have the responsibility and the accountability to follow through to make sure what you delegated actually got done. And that was where things were falling through the cracks. I could say, I need you to do this, but if I never circled back and said, hey, how is Mr. Smith? What were his vitals? How are things going? I may absolutely miss something. So it was very important to have that cycle. So as you delegate and you decide to delegate, determining the correct task, the procedure, or the function. Is it something that's within that scope of practice for that individual that you want to delegate to? Do you have available staff? And in the dilemma with the pandemic and what we're seeing now with these staffing shortages, sometimes we don't have available qualified staff. So do we have staff extenders or float staff that have come in to support the area that have the skills that can do the task? What are the assessment of the patient needs? Are they stable? If they're very critical, it may be working together with another person to achieve a task. Assessing the potential of the delegate's competencies. And this was very hard to do during the pandemic because people were being floated from all over the organization into high-risk areas, into COVID areas. And my background's perinatal, and I can take care of babies, I can deliver babies, I can do all kinds of things even in the NICU, but I'm not great with adult ICU. So it would be a challenge for me. So, you have to identify who's working, what their skills are, and what you can and cannot delegate. Considering the level of supervision that may be available or that needs to be there. So what we were finding is a lot of these articles also talked about that mentor process. So as I begin to delegate to you, I'm going to mentor and support you in that delegation until I am comfortable and you are comfortable with the task and that communication. So it becomes this very open two-way process as opposed to please do this, do that, do this. And we have to make sure it's safe. Again, as I delegate, I own it. I'm responsible and I'm accountable. So I've got to make sure that that person I delegate to understands that process. And avoiding delegating practices for things like assessment, evaluation, and nursing judgment. Those are things that have to be done by a licensed practitioner. And so only could I delegate to another licensed practitioner that had the same skills to be able to do those levels. So you can only delegate tasks as well for things that you're responsible. I can't delegate something that you might be responsible for. So as we begin to look at this process, it's transferring to a competent individual the authority to perform that selected task in that selected situation, but the nurse retains accountability. So again, in my OB world, I love this. You delegate someone to wash the baby. Well, this would be a completely absurd idea, I guess, but if this person didn't know, using a water hose might work, but it's not really a safe way to wash a baby. So having clear instruction, clear communication was also very strong across the literature. So defining the right task is critical, that right task piece. Deciding whether or not the situation or the circumstance is correct to delegate. So the right circumstance. Determining what, if any, of the task can be delegated and to the right person. So that person that would have the right skill level or has had the right training to be able to perform that task. Reaching that agreement, having that conversation with that individual to say, have you done this task before? Are you comfortable with this? Giving them clear direction on what you expect, when you expect it, and when you want information back about what happened in that process. So that right direction and right communication, and then monitoring the performance and providing feedback, that right level of supervision. This is where a lot of the articles talked about the fact that there was failure. Without having that adequate supervision and that adequate support, there were errors, there were missed opportunities, inconsistency in care, and those more negative outcomes. So helping to teach and support the supervisors or the person delegating to know what that feedback needs to look like was critical in terms of outcomes for the patients, but also for the nursing outcomes. From the legal perspective, and we also looked at what were from the boards of nursing and from legal parameters, there can be over delegation, under delegation, and inappropriate delegation. And making sure that nurses and any professional who is doing the delegation is comfortable with appropriate delegation. Under delegation is a nurse that's taking on too much and not letting go of anything. And we all do that as faculty sometimes. It's, oh yeah, I can do that, I can do that. And we do that the same as in bedside nursing. Sometimes, especially in a crisis, you don't want to overburden anybody else because you're feeling overwhelmed, and you may not delegate things that you should delegate. And so an error could occur. Over delegating is delegating all your work away and you're not doing anything. And that puts an excessive load on others that's not responsible. And inappropriate is delegating things that you should not be delegating, like assessment to someone that is not skilled. So there is that legal responsibility of the nurse to delegate a task. The nurse can delegate to another nurse. A nurse can delegate to a non-RN professional like an LPN or LVN. If in a clinic setting, it can also be to a medical assistant or a CNA, RN to an unlicensed person. The scope of practice is critical. And in looking in a global perspective, this would apply, I think, anywhere in the world, but really, what does your nursing standards? What are your rules and regs? So the standards, our American Nurses Association has a very clear statements around delegation, and other specialty organizations as well talk about delegation. So, what are your standards? What is your scope, and working within that scope? Also working within the employer's policies, procedures, job descriptions, competencies. Many of the organizations did extensive cross-training, really fast, quick, training. And we encouraged them to include the delegation training as part of that, because they were having to train labor nurses to work in med-surg units to take care of COVID patients, and helping them to know when to ask questions and who their resources were, and who they could reach out to for assistance. The unlicensed professionals, they need to have demonstrated capabilities and competencies for the task that's definitely assigned, and that RN needs to provide adequate supervision. This is an area where nurses can be held for malpractice. Nurses can lose their license. And so it's a huge liability of part of our practice, and something that people need to take very serious. So what we recommended after this review of the evidence is to assign an experienced clinician as the team leader, someone that works in that area, that is competent and can mentor and support the team. Mentor inexperienced staff. Make sure that there's someone there that if you've transferred into my unit and you're a different, your specialty is not in where we need you. What do you feel comfortable doing? Maybe it's starting IVs, maybe doing dressing changes. Maybe it's doing tasks more so than complex care. So let's figure out how we can set up the assignment and such that it's a win-win, but mentoring and supporting that process, following those 5 rights of delegation, and with an emphasis on communication, and that supervision feedback loop. Consider skill mix and competency of the entire team and begin to collaborate and look at what we need to do as a team to get the care done for this number of patients. And I know here at our local medical center, we had, physician residents, we had medical students, we had nursing students, we had everybody in the mix because we were so shorthanded that we had to be creative and pull teams together that learned and worked together and ended up producing amazing, wonderful, positive outcomes, but we learned a lot in the process. Other things would be, identifying that ideal model for inexperienced staff to develop skills. So having that process, so as you bring in those new people in this situation, what does that look like and how do we support them? Maximize staff experiences, their skills and experiences by offering during times when it's not crazy and you're not in a panic, offering extended skills, offering opportunities to gain more knowledge and exchanging that knowledge and skills across the organization. So with role delineations, absolutely clarifying the roles, what you need to do, how you can do it, how it would work in your organization within your policies, procedures, your parameters. And some of the literature said that that delegation and team nursing sometimes decreased role clarity, especially team nursing. The feedback from the patients were, I don't know who's my nurse. Everybody's wearing scrubs. They're all coming in and taking care of me, but I don't know who my nurse is versus the housekeeper versus somebody else. So there can be confusion. So as we work with patients and families, introducing ourselves, telling them our role, if we're going to have a team approach and whatever that configuration may look like, this is the team that's going to be providing your care. It's made up of these people with multiple backgrounds, and we're going to be coming in and checking on you. Any one of us can assist you, but I'm your primary nurse. So letting them, having that conversation can really help build confidence with the patient and family, but also help them feel more comfortable, with these different individuals popping into their room. So as we pulled this process together, one of our team created this visual image around, kind of the process of pulling team nursing and delegation together. And it's, again, assigning an experienced clinician as a team leader, mentoring that inexperienced staff, following the 5 rights, considering a skill mix of the team, as you're doing that, defining your roles clearly, using non-ICU or non-nursing staff to act as runners and to do non-clinical kinds of tasks, but more importantly, to collaborate as a team. And that's not just within nursing, it's an interprofessional collaboration across all disciplines. And because our goal is really to take care of those patients. Some additional resources that are out there, they're still out there for the pandemic, are, the Association of Critical Care Nurses and the ANA websites has some amazing resources. And I mean, I think I talked fast, but the whole process and what we identified was really, right now we continue to talk to organizations globally that are having huge crisis with nursing staff. We've had actually more inquiries recently than we did immediately after doing our webinar, because of the fact that this is something that they can consider. There's no perfect model. What we found is absolutely there was no, golden ticket. There was no perfect process, but what we did find is providing education, support around how to delegate made any of the models much more effective, improved patient outcomes, And it made staff feel better about, their own satisfaction with the process. Crisis can happen at any moment in time. I lived in Flagstaff, Arizona for 25 years, and we're up on the mountain, and we're the only medical center that serves people north of Phoenix, if you've ever been through Arizona. And there was a huge ice storm. And I think the last total was 175 car pileup in a snowstorm in the middle of winter. And basically our hospital completely went on disaster mode. Everything had to be completely rethought. And for 72 hours, we were treating those 100, and it was huge numbers of patients. The roads were closed. We couldn't fly patients to Phoenix or any place else. We had to manage, I think we had 100 and something admissions that were trauma types of admissions. We made it work. We had great patient outcomes, but it's amazing how you work under crisis. So this type of model could be something that could be looked at and planned for in those events of internal or external disaster or for pandemics. And it would work, I think, within any organization. So I'm happy to share our slides. We have a huge number. You'll notice I've got pages and pages of references, but I'd like to just go ahead and stop sharing. Let's see, get off of here. And that way I can take your questions. I can figure out how to stop sharing my screen there. There we go.
What a lovely presentation. Thank you very much. I was very intrigued, and two comments, and then we'll take questions from the floor.
Mhm.
Communication is what just glared at me underneath everything you said. No matter which team, no matter which model, without
Mhm.
communication, none of it works. And then I like the idea of the mentoring piece. It happens everywhere. And if we're not willing to do that, we can't bring those people up to speed that need to be. And so we all have to be open to that.
Absolutely.
But, does anyone else have questions? I'm always full of them, but looking for questions from the floor.
Yeah, I do have one question.
Yes, Janice.
What do you think of well, we've heard of medical scribes, right? The medical scribes are the ones who put all of the information into the computer for the doctors. I've often thought of having a nursing scribe that would allow for a lot of that transfer of information into the electronic health record. We have so many experienced nurses who are very hands-on and can do anything patient care, but really stumble when it comes to putting data into the electronic health services. Did any of your teams include or involve a technology scribe? Is that something you would recommend?
They didn't, but that was brought up from several organizations, that it was something that they were putting in place to just try to help offload some of the time for the nurses and the providers, and it was working. So I would think it would follow some of the same recommendations of the delegation. If you are doing, if I am, there has to be a process where if I'm doing the care and I'm capturing the data, but you're going to enter it, there has to be a way of showing that accountability, that I go back and make sure what was transcribed was correct. So there has to be some sort of follow through. But I know that there were several organizations that I've talked to over the last couple of years that have scribes in place, not just for their providers, but for their nurse practitioners and their provider teams. And it has worked well, but there always has to be that closed loop process to go back to make sure that there is some sort of a sign off, because we're human and we can make an error, and we just need to make sure that what was put in the medical record is correct and accurate. But I think it would be, it could be a really great time saver, especially if you're in a crisis situation like we've been in the last couple of years.
Yes, and I think it would encourage a lot of older nurses to stay in healthcare and help. Just have a scribe assigned to them, or one scribe per 2 or 3 nurses.
Right, that could help with that documentation, because I've been pulled back in as an administrator to help out during crisis. And it's like, I can do the care. I just can't do the charting because it takes me 10 times as long to navigate the charting because I'm not in there as often. And, but I've been a nurse for 42 years, so I can do lots of good care, just the documentation at every hospital is slightly different.
Mhm.
But I think that's a great point to look at.
Indeed, I've seen the medical scribes, and it's kind of cool to think that the docs, instead of then taking time between patients to put stuff in, it's already in. They just have to check it at some point.
Now, with the scribes that you're using, do they round with the provider and then, take the notes and then transcribed?
The ones that I've seen, yes.
Yeah.
They're putting in as they're talking, like it's all very fluid, and they
Mhm.
just go room to room with the provider.
And then the provider probably just signs off at the end of the shift or end of the day.
That would be my guess as well. So,
But I
better.
think it does free the person up to be able to do more hands-on. And I think for patient satisfaction, it's probably much higher because the doctor or the provider is right there with the patient as opposed to at the computer doing this.
I had a student that I teach a technology course, and there's somewhere here in the Pittsburgh area that they actually have a computer program that the nurses wear an earpiece, and they
Mhm.
chart as they do by talking. They talk into the headpiece, and it does the charting for them. My guess is they have to have certain keywords to activate the different systems, and then they would go back at the end of the shift or the end of assessments, a whole round of to make sure that it charted
Mhm.
correctly. I thought that was kind of cool too. It keeps you hands-on with the patient and not at the computer.
Oh, definitely. And I'm excited to see, I think that you're going to see some new research and publications around the whole staffing issues that have occurred over these last couple of years. Because globally, we have had to do some really interesting approaches to make sure we have enough staff to care for patients, not just our COVID patients, but for patients in all of the other areas that still needed the same levels of care. And that we had to be creative and innovative in how we manage those patients. So who knows, we may end up with a better model out there than we've ever even thought of.
Right. And I'd like to think that we as nurses do that drop back and punt really well.
Yep, absolutely.
All right. Well, thank you, Dr. Beckett, for your presentation. We're going to move on to the next
Thanks very
presenter.
much.